I would just like to say a huge welcome to Dr. Hack, who has joined us today, and we are thrilled to have you with us, Doctor, from the Rutherford Cancer Centre to talk about palliative medicine. It's an area that I think people worry about quite a lot, but I think understanding it and knowing what to expect is actually probably a good idea if that is something that you are dealing with. So I will let you start your discussion, and we can go from there.
Okay, thank you, Vic, for introducing me. I am a palliative care physician, and I'm working in London at the moment. And my main interest in palliative medicine is in a concept that was developed at Christie's recently called enhanced supportive care. What that really just means is that early palliative interventions in patients with cancer, which can improve quality of life and even prolong life in some cases. And this is the newer model of palliative care that is being envisioned in this country. Just to give you initially just an idea of what palliative care is, I think it's developed in this country over many, many years, so you may all be familiar with the concept. But just to reiterate, it's about providing support and advice to patients and families who are afflicted with cancer, and doing all of this, keeping in mind the quality of life of those patients and those families looking after those patients. That's the key goal of palliative care. And we do this by good medical management, which includes management of symptoms like pain and some others that I want to discuss today with you, which are the commonest sort of things that we see within our practice, but also providing emotional support, spiritual support, social service involvement, and any other kind of support, and linking you up with services like the one that you have locally and others that can enable you to support you even more. So I want to talk to you briefly about palliative care and the major symptoms of palliative care that we generally deal with, and also to introduce you to this idea of integrating oncology and palliative care, where you get the treatment for your cancer, but the other aspects of your care, like symptom management or emotional support or social support, the other things that are just as important to quality of life, are not overlooked. So at the Rutherford Cancer Centre, which is an ambulatory centre, I think this is an area that we are now developing within the cancer centre, where patients can access early palliative interventions for troublesome symptoms, whether they are caused by the cancer or whether they are caused by the treatment of cancer. Could I have the next slide, please? So just to allude to the four really main, I mean, obviously patients with cancer can have lots of problems, but pain, nausea and sickness, breathlessness, tiredness and fatigue, there's hardly a patient that I see that doesn't have at least one of those symptoms or a combination of those symptoms. So I'm just going to describe these briefly to you and the sort of things that we see. I thought they may be of interest for you to see how we approach this and how we manage this. Could I see the next slide, please? So pain, I think cancer pain is, I think 8 out of 10 people in cancer, we think, have pain at some point during the cancer journey. The exact prevalence of cancer pain, nobody actually knows, because there are different areas that have looked at it. I mean, if you go on a hospice ward, you probably have 100% of people having some level of pain being managed. If you look at an acute medical unit, perhaps that's less. If you see people in the community in a GP practice, then there would be even fewer people. But people with cancer generally have pain, and it's often a severe, unremitting type of pain. It's usually related to cancer or its treatment. For example, cancer affecting the bone vein, cancer affecting the liver can cause the stretching of the liver capsule, causing a lot of pain, and other organs can be similarly affected. But pain can also be related to treatment. I mean, you might be familiar with cancer treatments that can cause nerve damage, for instance, causing neuropathic pain, or cancer treatments that cause a burning of the mouth called a mucositis, a radiotherapy that can lead to severe ulceration and pain in the mouth and along the gut, actually. And these are pains that we see with cancer treatments. And palliative care, you know, I think you may all be familiar with, when you talk about palliative care and hospice care, I think you get images of death and dying in hospices and stuff. But I can tell you that within cancer centers, specialist palliative care is working alongside oncologists dealing with these problems. And that's the sort of model that we want to develop at Rutherford. While you're having your treatment and you have other symptoms that are troublesome or difficult, we can manage them. And this is just one example, like mucositis, neuropathies, and other pains that you might have. The pain from cancer is often complex. So what I mean by that is that if you had a broken bone, for instance, you would have bone pain. So you had a fracture, you have bone pain. But the way the cancer spreads, there's often more than one type of pain. So the cancer affects your spine, it's causing bone pain, it's wrapping up the nerves, causing neuropathic pain, it's involving soft tissues and muscles around the spine, causing soft tissue pain. So what that means is that the pain it requires a multidisciplinary approach to managing the pain. You may not be able to get rid of that pain with simple analgesics, but the types of analgesics that we use can be more than one. And usually you will see people with cancer pain on opioids. There's a great fear of opioids that I find in people who have never had them. But once you've had them, I think a lot of the fears are allayed of patients who go onto opioids. They're excellent drugs for managing pain, but they need specialist advice and care in the way we use them. Some patients that I have will drive to work still with opioids, which they're taking for cancer pain. For example, patients with prostate cancer, with bone disease, if you manage their pain well, and they are on morphine or similar drugs, they can still drive and go around. It's not a drug that we use in end of life. It's a drug that you can use at any stage of the cancer journey. And then there are other drugs that are neuropathic agents, gabapentin, pregabalin. I mention these names because I know in the audience there may be people who are using these drugs. It's always worth remembering the role of adjuvants. We enlist the help of others for managing pain as well. So radiotherapy, for instance, which is particularly relevant to the Rutherford, is hugely helpful in managing bone pain. 80 to 85% of people will respond to radiotherapy, albeit there can be a flare response in the first week, which we can manage, and then the pain abates. And similarly, you can have nerve blocks where you inject anesthetic agents, often combined with steroids, in specific locations that cause pain. So for example, if you've got a lesion somewhere in the spine causing pain that travels around, then a nerve block along that nerve can actually alleviate the pain quite a lot. Similarly, pancreatic cancers, pain can be alleviated with that. And there are a number of nerve blocks that we can use. And those, there are specialists, usually they're anesthetists who are specialized in this area. So we do use them to help alleviate pain. Such patients reduce their tablet burden sometimes, and sometimes the pain response is dramatic. And similarly, acupuncture as well has been used and is available on the NHS actually. At the hospice that I work at the moment, every Friday we have an acupuncture specialist who comes here, and we regularly send our patients there. I think it's important to say that it's not just the medical management of pain. There is the concept of total pain. Pain is an unpleasant experience. And as an experience, it can be allayed not only by medication, but I think just talking to patients who have total pain, where an emotional aspect of pain can also make the pain a lot worse. So unless you deal with that side of things, sometimes the pain never gets better. You have to deal with it in a total way. And I think this has been alluded to in palliative care as holistic assessment of patients. On the right side, I've just shown you a very basic way of measuring pain. Obviously, we can't measure pain like we measure blood pressure. We don't have a meter for it. So some people express it verbally as mild to moderate or severe. Some people are happy with a numeric pain intensity scale that is seen there. Or some people just want to mark on a visual analog scale where you can see there's no pain on the left side, on the right side, worse pain, and they will mark themselves where they are. And then, of course, the faces that are particularly helpful for the younger people as well. So there are different pain scales, and we like to assess people and mark where they are when we first meet them. And when we do an intervention like medication or radiotherapy or whatever we're doing for his pain, we would want to go back and mark that scale again to see whether there's been an actual benefit or not. So pain, it's unlikely that I will ever see a cancer patient that has no pain. That does happen, but I think that's a rare event. It's an event that happens very, very commonly. Can I have the next slide, please? And that's just alluding to the different types of pain. There are pills we can use. We often use a combination of medication. I think when I'm using drugs, I think you have to be very cautious about the side effects of treatment. So opioids can give you constipation, but we can manage that. Other drugs have different effects. I think it is part of our training to be able to identify risks associated with treatment, and we will always use the safest option. The spine on the top, on the right-hand side, is just an example of somebody being injected with a nerve block. That's what it looks like. Each individual bone is a vertebra in your spine, and between each one of them, there's a nerve that is coming out on both sides. And that's where the injections are given to numb that nerve to be able to take care of pain. Obviously, the different types of nerve blocks require different types of techniques, and I haven't shown all of them there. Radiotherapy, of course, as I mentioned, is particularly helpful for bone pain, and a lot of patients have bone mets. And then obviously acupuncture, that I'm sure that you're all familiar with. I have to say you get a variable response from patients, but I think when we are stuck, we try different things, and sometimes you get a very, very good response. Could I have the next slide, please? Breathlessness is another thing that we come across. I put in some X-rays and CTs to show the different types of breathlessness. On the left top is a normal chest X-ray, really. And then if you look at the top right, that's somebody that's got fluid accumulation on the right lung. And that is best treated by taking that fluid out. You may have experienced this yourself or seen that or heard about it. You can put in a drain, take out the fluid, and the lung expands and you can breathe again. The middle left is called lymphangitic carcinomatosis. What that really means is cancers can sometimes affect the lungs in a way that it spreads out like a spider's network, if you like, involving the very small airways, which is where your oxygen is being transferred across. And that is seen more clearly on a CT scan on the right-hand side. That is in the middle right is a CT image of a slice of the lung. Just to explain what the CT is, in the middle is your heart and lungs and your vessels. On either side are your lungs, and they should normally be black. The white streaks that you see in those lungs are the spread of cancer in those lungs and making that patient breathless. Now, how do you deal with that? You obviously optimize as much of the cancer treatment as you can. You do the medical management of it, but then there is a point where the cancer can't be treated, and the breathlessness has to be treated in a different way. And that's the palliative approach to the managing breathlessness. And there's oxygen that you use. You optimize medical treatment for whatever the condition is. But then there's a judicious use of low-dose morphine, for instance, and other physiotherapy and occupational therapy modalities that are brought in to help with that breathlessness. Because ultimately, if you look at it, breathlessness is a perception. Dyspnea and breathlessness is like pain on a scale. So you can't really measure it. Oxygen levels do not equate to breathlessness. So people can have normal oxygen levels or near normal oxygen levels and be quite breathless. So it's again more an experience, not just a physical entity. And the way we deal with that in palliative care is to deal with it with medication, but also deal with it with other specialties supporting us, particularly physiotherapy and others that teach patients of how to deal with breathlessness and how to deal with the anxiety that comes on with the breathlessness, and so on and so forth. So that the palliative approach to this, so there is a point where the medical management of reversible causes stops. There is nothing reversible, but you can still help patients. They don't have to be struggling with their breathing. There are things you can still do for them. And that's the palliative specialized approach to it. Can I have the next slide, please? Fatigue. If you look at some of the studies in cancer patients, fatigue appears to be the commonest symptom of cancer and in cancer survivors. There's some studies that report 100% of their patients had fatigue of some level. Fatigue is multifactorial. It's multifaceted. It can be caused by something like high calcium levels. It can be caused by anemia and a number of other medical conditions. But it can be caused by depression. It can be caused by poor nutrition. It can be the effect of chemotherapy or radiotherapy. And so it requires a very good assessment to start with. And wherever possible, the treatment should be directed at its cause. Treating anemia, for instance, can help fatigue, but not in everyone. And what I mean by that is that because fatigue is multifaceted, I might see somebody, and I see that every week, you might see somebody who's anemic. You give them a blood transfusion, and then you ask them whether they are any better. And I think about 50% of these patients will turn around to you and say, well, no, I'm no better. what that means to us is that their fatigue is not just related to anemia. It's not just a medical issue. We need to delve deeper and try to find what other things are contributing to fatigue. Fatigue can be in advanced cancer, for instance, or cancer that has spread. Fatigue can be very much part of the disease burden. Just the presence of cancer. The cancer produces, is very interesting. Cancer produces a number of chemicals, a number of hormones, things like interleukin-1, for instance, that takes away your appetite. You may have heard about cancer cachexia, the sort of weight loss that occurs with widespread cancer, where essentially any calorie that you are giving them isn't really helping put on weight. These chemicals that are released by cancer, like the interleukins, etc., they actually reduce your appetite, and that reduction of appetite then leads to further weight loss. And I think there is a point within the cancer journey where a good nutrition is important. There's a point in the cancer journey, very advanced cancer journey, where it's important for patients to enjoy what they're eating more than worrying too much about calories and what they're eating. And so cancer cachexia and fatigue go hand in hand. Some medications, particularly steroids, have been the mainstay for managing fatigues. They will work in some cases. In some cases, they don't. You want to find the minimum dose that works. Often, within a couple of weeks, you need to increase the dose or the effect becomes less. So you need to look at non-medical ways of dealing with it. And here, physiotherapy and things like just spreading out the chores in the day help quite a lot. So you sort of wake up in the morning and you may be okay. You do most of your stuff in the morning and then you plan your day accordingly. So those are the things that can actually help fatigue if there's no remediable cause. But obviously, the job of a physician initially when you make an assessment is to make sure, look at anemia, look at other electrolyte abnormalities, calcium levels, etc., things that can be fixed, and that can help. Can I go on the next slide, please?
Oh, hang on. It's that one, isn't it? That is the next slide, that one there.
Next one, please, after that.
That's the last one I've got.
Oh, really? Oh, okay. So I think the rest of it is not about pain management, really. It's just about introducing you to this model of enhanced supportive care. And as I said earlier, enhanced supportive care is, I suppose it is a positive approach to palliative care for patients. I mentioned earlier about palliative care and hospice care. And whenever patients have been referred to palliative care, there seems to be, the whole image of palliative care is about death and dying and so on. And I can tell you that I've seen patients in the hospital. I'll tell you a very interesting example. When I was working in Wales, there was a patient with breast cancer referred to me, and I introduced myself as a palliative care physician. And she immediately said, well, I'm not there yet. And I said, what do you mean by that? And to her, palliative care was just about end of life. And I said, look, I'm here to I've been told that you've got pain, and I need to make this pain better. I think it's very easy to give chemotherapy and continue and focus on that treatment. But I think it's that journey of cancer that has to be made better for patients so that the quality of life of patients is better with that as well. And I think that can't be forgotten. And this has been recognized increasingly. And some years ago at the Christie, they rebranded palliative care almost as enhanced supportive care. And this was essentially, and the key to that really is because of the recognition that what specialist palliative care can offer to patients with cancer. And there's good evidence that providing early palliative interventions for symptom management, for supporting patients with cancer, actually prolongs life. So in 2010, there was a paper that came out of the US about patients with stage 4 lung cancer. And that's very interesting because they did a study where they randomized patients to either standard cancer treatment, and the other half were randomized to standard cancer treatment, but were also offered specialist palliative care at the time of diagnosis of stage 4 lung cancer. So this was not early cancer, this was stage 4 lung cancer. And two arms, one of them just the regular chemotherapy, and the others were offered palliative intervention and chemotherapy, obviously, at diagnosis. And what they found was that the quality of life in people offered palliative care and the incidence of depression was much better. But what was surprising is that they lived 3 months longer as well. Now, I put it to you, if you had a new chemotherapy today that would prolong life in stage 4 cancer by 3 months, that would become the standard of care. And that recognition has led to the early palliative care involvement in cancers such as lung cancer, upper GI cancers, cancers where we can't find the source of the cancer. So where patients present with widespread disease. And that is what has led to the early involvement of palliative care. And what that means in practice is that we would work jointly with oncology. So if previously you had cancer treatment and then you waited for everything to stop and everything failed, and then you were referred to palliative care for end of life, that's now changed to you've got cancer, you're on cancer treatment. Let's say you've got advanced disease, but palliative care zooms in and out, if you like, for specific issues. So if you have severe pain or fatigue or breathlessness, other things, you can actually get palliative care involvement early on. And once we fix this, you go back to your oncology treatment and you continue with that. So your cancer journey, the palliative care is involved more in the cancer journey now, not just at end of life. And this can be done by a specialist via face-to-face. At the Rutherford, we're setting up a pain clinic, particularly, but there's no reason why we can't look at other symptoms, common symptoms in cancer in the same clinic. You can have access perhaps to physiotherapy, enabling you to live as actively and as well as is possible, for as long as it's possible. That's the ultimate aim of treatment. So maintaining, I suppose, this approach maintains hope for patients. And I think that's a great thing, because the changing demographics of cancer, patients are living longer. There are more treatments coming out that are allowing people to live longer. That means there is a higher symptom burden. Somebody has to be looking at giving them more than just the chemotherapy and radiotherapy. They've got to integrate that side of care with oncology. And when you do that, that's when you get the best quality of life. And in some cases, as I've alluded to in lung cancer, people are living longer because of that intervention. So I'll stop there. I hope that shows what palliative care is about. But also, I wanted to introduce you to this early enhanced supportive care model. It's not just about end of life at all. My life would be very boring if I just saw somebody who was dying all the time. That's very much part of palliative care, and we can enable difficult end-of-life decisions and treatments. But at the Rutherford, I would hope that we would see people who are ambulatory, who walk into the clinic, who have the oncology treatments, and then we can do something for them at the same time.
That's brilliant. Thank you.